Kettner, we are at the top of the hour if you'd like to begin.
Thank you very much. Well, good afternoon, and thank you for joining the Superior Health Quality Alliance webinar entitled Nursing Home Telehealth Policy, the Basics and COVID-19 Implications. Superior Health is comprised of 8 member organizations across 6 states. Our goal is to collaboratively improve the quality of health and health care for consumers, patients, clinicians, organizations, and the communities we serve. My name is Toni Kettner, and I will be your moderator for today's call. I'm being assisted by my colleagues Candy Hansen and Julie Bannister. We would like to take this opportunity to welcome nursing homes in Wisconsin, Michigan, and Minnesota to today's call, as well as other stakeholders that have been able to join us today. As a reminder, all lines will be muted during the presentation. This session is being recorded and it will be made available on the Superior Health QIO YouTube channel. For your convenience, the link to the Superior YouTube channel, as well as the link to today's PowerPoint presentation, will be posted in the chat box. Finally, there will be a short evaluation following today's call, and we really appreciate your feedback. The link to that evaluation will also be posted in the chat box for your convenience. So we ask that you take a few minutes to complete that at the end of the presentation. There will be an opportunity to ask questions at the end of the call, and you can do this in one of several ways. Please feel free to post any comments or questions in the chat box, or at the end of the call, you'll be able to call via telephone for those of us who have joined us that way. Pressing *6 will unmute your phone, and pressing *6 will mute your phone again. Without further ado, I'd like to introduce our guest speaker today. It is my honor to introduce Mei Kwong. Mei joined the Center for Connected Health Policy, or CCHP, in March 2010 as a policy associate and was named executive director in January of 2018. Ms. Kwong leads the organization's work on public policy issues as they impact telehealth at the state and federal level. She is also the project director for the National Telehealth Policy Resource Center. Ms. Kwong is nationally recognized expert on telehealth policy. In her current role at CCHP, she works with the organization's multitude of national and regional partners on telehealth issues and oversees CCHP's projects, provides policy technical assistance to state and federal lawmakers, as well as industry members, providers, consumers, and others. She manages CCHP staff and works closely with CCHP's consultants. She has been published in peer-reviewed journals and is sought after as a speaker at national conferences. Prior to joining CCHP, Ms. Kwong was a public policy analyst for the Children's Home Society of California, working on child care and early education issues at the state and federal level. She's also worked extensively with the Child Development Policy Institute, a statewide public policy organization, and was recognized by them in 2014 for her work in the early care and education field. Prior to that, she was at the National Association of Real Estate Investment Trusts in Washington, D.C., working on federal tax issues and administered that association's Political Action Committee. Ms. Kwong holds a BA in International Affairs from George Washington University and a Juris Doctorate from George Washington University Law School. Mei, it's an honor to have you.
Thank you, Toni, and it's an honor to be here today. And I just realized that was actually a very long bio, so I apologize for that. But I am Mei Kwong. I am the Executive Director at the Center for Connected Health Policy. Next slide, please. And as Toni mentioned, I'm an attorney, so I always have to start off with a disclaimer. So for today's talk, I'm not providing anybody with legal advice. This is purely for informational purposes. CCHP always recommends that if you are looking for a legal opinion, please seek out legal counsel. And if I also happen to mention a company or show some type of product, know that neither I nor CCHP have any type of arrangement or relationship with such a organization. Next slide, please. So a little bit about CCHP. You heard probably way too much about me. So a little bit about CCHP. We actually were established in 2009 to be a California telehealth policy organization. We're a program underneath the Public Health Institute, but an opportunity to become the National Telehealth Policy Research Center became available through a grant from HRSA in 2012. We applied for that and we've been serving in that capacity ever since. But we also work with, as Tony mentioned, a variety of other partners on specific telehealth projects or connected health projects. And that's a listing of some of the partners that we have. Next slide. Some of the things that we do is we do a 50-state report on all of the Medicaid telehealth policies, laws, and regulations for all 50 states in the District of Columbia. We also act as the administrator for the National Consortium of Telehealth Resource Centers, and I'll explain that in a second. And we also do a special project in California because we're based here. We're the convener for the California Telehealth Policy Coalition, which is a coalition of over 70 statewide organizations that are interested in California telehealth policy. Next slide, please. So I mentioned the National Consortium Telehealth Resource Center, and I think they are going to be a very valuable resource to all of you guys. So there are 14 telehealth resource centers, 2 nationals and 12 regionals. CCHP is one of the national telehealth resource centers. We're the one on policy. The other national focuses on technology. And then there are 12 regional resource centers that cover specific state. So we all work together very collaboratively. We also formed this organization called the National Consortium of Telehealth Resource Centers so we can work more closely together and make our funds go more efficiently so there's no overlap in work, duplicativeness in work, and that we send out the same message and information to all constituents. The 12 regional resource centers, I said, cover specific states, and they are more sort of the program, operational, on the boots ground folks. So if you have questions about telehealth, please reach out to your telehealth resource center. I like to say that for the most part, we can probably answer your questions 99% of the time. But if somebody runs into an issue and they can't answer the question, they have the other 13 to go to see if somebody else has the answer, and usually somebody does. And then that 1% of the time where we don't have the answer, it may not exist, or somebody will go down and try to hunt down the answer for you. So definitely reach out to your resource center if you have questions regarding telehealth, if you're interested in starting a telehealth program. That is why we're here. So please reach out to us if you need some help regarding telehealth. Next slide, please. Oh, and by the way, since it's federally funded, most of those services are free, so don't worry about that. So you can definitely reach out to them, get some free services. So I mentioned the 50-state report that CCHP does. So we track all of the telehealth Medicaid policies, state laws, and regulations, as well as on the federal level. And this is a pretty onerous task. So the report that we usually do, it's about 450 pages total. But what we also do is we make it available publicly through an interactive map on our website. So instead of downloading the entire PDF of 450 pages, if you're just interested in one state, you can click on that state and it'll bring up all the information for you. That is actually a screenshot of our website and our interactive map. We do this update twice a year, once in the spring and once in the fall. The information on the website currently is good up through October 2019. We were actually in the middle of our spring update when COVID-19 hit. So the spring update, which will have information good through February 2019, does not include the COVID-19 stuff because a lot of that is temporary and that's located in a different section of our website. But the information for up to February 2019, which is still applicable, that will be available within the next couple of weeks. We're finishing up our update right now. Next slide, please. So just to make sure everybody is on the same page, I'm just going to cover a couple of basics. And for those of you where this is old hat, you can go get a cup of coffee. So this will just take me like a minute or two to do this. So some of you may have heard the terminology telehealth and telemedicine. And what's the difference? It really depends. So there's a couple of ways to approach it. So it could depend on the state that you're in. There may be a statutory definition for the term. So they may have a very specific definition of a state on for telehealth or telemedicine. But usually a lot of times the two terms are used interchangeably. rule of thumb, telehealth is usually the broader term. Telemedicine is usually used for the direct provision of healthcare services, whereas telehealth can encompass many other things such as, education or maybe provider-to-provider consultation. So for this presentation, we're going to use the term telehealth. A couple other terms that you may hear a lot, and I am guilty of this because I'm just so familiar with it. I may use just these terms and assume everybody knows what we're talking about, are things like originating site or originating site provider, or distance site and distance site provider. So we'll just go through a couple of these terms. Your originating site is essentially where your patient is located. So that could be, in your case, a skilled nursing facility, but it may be other locations such as a hospital, doctor's office, or now COVID-19, for a lot of people, it's the home. When you hear originating site provider, that means an actual healthcare provider who is with the patient at the time that the telehealth interaction is taking place. Distance site is where the telehealth provider is located, the actual provider who's providing the services via telehealth. In most cases, it's usually considered the specialist, but again, with COVID-19, your distance site provider may actually be a primary care provider as well. So that's what distance site means. Modality, that simply means how the service is delivered. And there's 3 different common modalities related to telehealth. So the first one is live video, which is probably the one most people are familiar with. It's literally what we're doing right now. It's that real-time interaction between a provider and patient, or sometimes between provider and provider. It's also the most commonly reimbursed type of modality out there by payers. Then you have something called asynchronous, or maybe referred to as store and forward. And it's kind of self-explanatory. It's this capture or storing of an information and you're forwarding it to the telehealth provider. So for example, think about you go into your doctor's office and you've got a skin condition. You're not quite sure what it is, and your doctor isn't quite sure what it is. Takes a picture of it, sends it over a secure system to a dermatologist for a diagnosis. They communicate with each other on what needs to be next steps. So you're storing the information and you're sending it to a provider who is looking at it, not in real time as it's coming in, but at a later time. So for a skilled nursing facility, there's actually a lot of store and forward done with wound care. So like a particular condition on the patient or the resident that they're not quite sure how to treat, or they have questions on, they can send that to like a wound care specialist to look at. Then you have the third modality, which is called remote patient monitoring, and this can be both in real time or not in real time. So a real time remote patient monitoring, which is just a continuous monitoring of a patient, might be in an ICU unit. So your intensivist may not actually physically be there with the patient, but maybe monitoring from another location, and is directing healthcare personnel who are actually physically there with the patient to do things if they need them to do something. But they're doing that in real time. They're not, storing information and looking at it at a later time. A non-real-time version of remote patient monitoring might be somebody who has a chronic condition and is at home, maybe taking measurements. So for example, somebody who has hypertension, their provider wants to monitor that. They're taking blood pressure readings, maybe like throughout the week, and then they're sending it to the provider who's not looking at it as they're coming in, but looking at it maybe at the end of the week or at the end of the day. And then if there's something there that they have concerns about, say like, hey, on Tuesday, why did you spike? What were you doing that day? What were you eating, etc. And then there are other types of terminologies that you may hear that kind of fall into these 3 modality categories. So the modality categories are kind of your large categories. And then you may hear other terms of like, how you use telehealth that fall into like using these modalities. So one of them, for example, is something you may have heard of called e-consult. And I realize that has different meanings for different parts of the country, which is another complication about telehealth, is that different parts of the country have different sort of meanings for the same term. But e-consult, for a widely viewed definition for that, is a provider to provider consultation. So 2 providers, patients not involved at the time of the consultation, but 2 providers consulting with each other. Sounds really closely to like store and forward, but where store and forward, sometimes the specialist or the telehealth provider might take responsibility and oversight over like the patient's care. With an e-consult, what happens is you have one provider send all the information and consult with another provider. Again, usually it's primary care provider to a specialist, and then the specialist sends back their recommendation. That is this care of the patient stays with the primary care provider. So that's called an e-consult. And then again, that can also take place in real time or not in real time. You may have also heard the term echo related to telehealth. And what that is think of technology doing grand rounds. So you have a provider who goes to a panelist of a bunch of specialists and says, this is my patient. They present the patient's case. And then the different specialists gives their recommendations back. Again, the care essentially stays with the provider who is presenting, and then the provider who's presenting goes back and implements the recommendations if they so decide it's best appropriate to do that. So that's more of an educational type of interaction and consulting type of interaction. And echo usually takes place in real time over live video as well. So next slide, please. So hopefully that set sort of like a ground level for all folks here. Now, questions are, why if you're in a long-term care facility or a skilled nursing facility, why even consider telehealth to begin with? I mean, what's the big deal with it? And before COVID-19, there was a lot of interest in skilled nursing facilities in doing that because with telehealth you can increase access to services. Perhaps you're in an area where there's a shortage of certain types of specialty providers. You can increase that access to them through telehealth by reaching further to find more specialists who may be further away but could do the service over telehealth. You reduce the amount of transportation. Again, you're engaging with providers in the actual facility itself instead of having to transport the patient to an emergency room or to another provider for like their appointment or something. You can do that with telehealth, just having it the resident there within the facility as opposed to like having to transport them. And also there's less stress on the resident. When you're having to transport them, it could sometimes, depending on the resident, it may be a larger sort of investment of resources in like needing to transport them. Perhaps they need a special vehicle or more personnel to help you transport them instead of like hey, everybody just gets into the car and go. So there might be less stress on the resident, especially if they're not feeling well and maybe it's not best for them to be in a car ride or something. So that was another benefit of like using telehealth in a long-term care facility. During COVID-19, one of the biggest thing, and this goes for not just long-term care facilities and SNFs, but basically everybody, one of the benefits of telehealth reduces the amount of exposure, not only for residents in that they're not going into places where there is a higher likelihood of the virus being present, such as an emergency room, but also for the healthcare worker as well. So there's protections on both ends of using telehealth and reducing the amount of likelihood of exposure. So that is like one of the big reasons telehealth is being turned to during COVID-19 is not only are we having people shelter in place, so you need to get them services in some way, but the benefit is you're limiting exposure for everybody involved. Next slide, please. So if this all sounds so great, and it made it sound really great, why wasn't there more implementation of telehealth in long-term care facilities before COVID-19? And the reason is like what a lot of other folks faced when they're talking about telehealth and why telehealth wasn't more widespread before COVID-19. One of the biggest ones is reimbursement and other policy barriers. So there are a lot of the existing telehealth policies that are in statute or in Medicaid and Medicare right now. A lot of that really has to do with the reimbursement end. So there's like a lot of limitations on like who and how you can get paid and what you can do to get paid. Although there are other policy barriers that I'll get into as well that inhibited the use of telehealth. Second one is broadband, especially if you're in a rural area. You may not have the connectivity, and basically telehealth doesn't work if you can't connect. So you need broadband, and not everybody had that robust capability. And we're not talking about, hey, I have dial-up or something. That's going to work. It's like, well, probably not. You need a robust sort of connection in order for telehealth to continue to work. Equipment costs, which is something in the past I've heard from SNFs and long-term care facilities as being a significant issue, is along with broadband and all the other issues, but also equipment costs. And like, you may not have had actually the discretionary funds to pay for equipment to like have that in place. And that's not only just for SNFs and long-term care facilities, but I deal a lot with community healthcare clinics, like federally qualified health centers and rural health centers. They've also run into that issue of like maybe not having the proper equipment to use telehealth. And then a big one, just kind of your X factor, is awareness and education. So providers maybe are obviously more familiar with telehealth, but you talk to the average person out there, they're not going to understand what telehealth is most likely, or even be aware that it's out there. I've been doing this for 10 years. Until COVID-19 hit, I think I still had family members and friends who were still confused as to what I did for a living. So it's not something the average person who's not related to healthcare would probably understand or know it was available. And I think that was part of the issue of like why telehealth never tipped over, is because you didn't have that high consumer demand saying like, hey, policymakers, why are you forcing me to go into the doctor's office for like a quick checkup when I can do it over video? Why aren't you letting my doctors do that? So there was like not that consumer awareness and education, I think, for the consumer as well. Next slide, please. So the existing telehealth policy, and as I said, a lot of it exists now, the policy and what's on the books really relates to like what's paid for when you use telehealth. And that can be broken down into like more certain buckets in like where they will have like certain restrictions or certain policies regarding. And that's location, the type of modality that's used, who the provider is providing service, and the actual service that will be covered. Now, where SNFs are concerned in long-term care facilities, location probably be like sort of the first hurdle you need to get over, is like what you guys are you an entity that's eligible to have like telehealth take place in your facility, and like the provider will get reimbursed. So that's usually the first hurdle that I was thinking of that you guys would need to overcome, is if the policy allows a skilled nursing facility or long-term care facility to be that eligible originating site. And then you have all these other hurdles that you need to go through, the modality, the provider, and if the service is covered. Next slide, please. So who pays for telehealth? So who are these people out there who are making all these policies, making it difficult? What are sort of the major payers? So you have your Medicare, which is on the federal level, and then you have your Medicaid, and then your private payers. And then how else you can pay for telehealth is you pay for out-of-pocket. I'm not going to really spend a lot of time out-of-pocket, because out-of-pocket essentially has the least amount of restrictions, because there's nothing out there that says you can't provide a service via telehealth. There's other kind of rules you have to follow, such as like licensing rules and, if you're prescribing stuff, prescribing laws and all that. But there's nothing anywhere that says like you can't get a service via telehealth. It's just a matter of like, will these insurers pay for it? So if you're paying out of pocket, you kind of have less restrictions around you. So really got to focus in on the top three there. Next slide, please. So as many of you are probably aware, there's been a lot of changes during COVID-19 on telehealth policy. And the ones that probably get the most attention is CMS. Part of that is because prior to COVID-19, Medicare had one of the most restrictive policies around telehealth reimbursement out of everybody. A lot of states were a lot more forward-thinking and broader in their policies and what they would cover. So CMS, the reason they had to make a lot of these changes is because there were a lot of barriers in CMS. So CMS policy, also keep in mind that there was a limit to what CMS itself could do, because a lot of the Medicare policies around telehealth were embedded in federal statutes. So it literally takes an act of Congress to change some of these barriers, or to at least temporarily waive them, which is what they've done during COVID-19. So again, our big buckets of issues that we're looking at is like location, what services are allowed, what modality is allowed, and also the types of providers who are allowed to provide services. So we'll take location first. And one of the biggest barriers on providing telehealth in Medicare and getting reimbursed for that had been the location of the patient. Now, skilled nursing facilities were an eligible site even before COVID-19 where telehealth could take place. However, probably what impacted a lot of skilled nursing facilities was that you needed to be in a certain type of geographical location. So prior to COVID-19, you had to be in a rural or non-metropolitan statistical area, and CMS had a very specific definition of rural that so specific and so limiting. I'm from California. 98% of the state of California was ineligible to be an originating site geographically underneath the Medicare rules. So what Congress did is they have temporarily waived that geographic limitation. They've also waived where the specific site where the patient could be located. Most likely because everybody is sheltering in place, everybody's at home, and prior to COVID-19, being at home, they only allowed it for a very small set of services. So the location of the patient, those limitations have been waived in response to COVID-19. Eligible list of providers, specific list of providers who can provide services via telehealth. And I think this is probably another area that could have impacted skilled nursing facilities and long-term care facilities. So eligible providers were very, very specific lists. So it's about a list of like 10 different providers, your doctors, dietitians are on there, midwives are on there, and some mental health providers on there, and that was about it. One of the biggest issues was that federally qualified health centers and rural health clinics were not on the list of eligible providers. So in this emergency situation, that's been waived as well. And I think it's likely probably that for skilled nursing facilities and long-term care facilities, especially those in rural areas, you probably would have had or have federally qualified health centers and RHCs providing those services to the skilled nursing facilities. Underneath Medicare, they wouldn't have gotten reimbursed for that pre-COVID-19. During COVID-19, they are with some conditions, and I'll get into that in a bit. Modality, that actually has not changed yet. So modality, basically underneath CMS, it was live video unless you're in Hawaii or Alaska, then they allowed store and forward. They're still only saying it's live video for now. I've heard rumors of other things. So telephone is not allowed underneath their telehealth policy. Again, I'll get into this later, but there's a set of services underneath Medicare that they call technology-based communications that essentially use telehealth technologies, but it's not called telehealth, where they will allow phone and other things to be done. So I'll get into that a little bit later. And it's very, very important for you to understand that you have sort of like two groupings of services where Medicare is concerned. Even though they both use telehealth technology, you have stuff that they call telehealth, and then you have other stuff that they call technology-based communications or communication-based services. And the reason for that is the telehealth stuff, they need to follow federal law and all those restrictions. Technology-based communication stuff, they don't, because it's not called telehealth. So they have a little bit more flexibility there, but I'll talk more about that in a moment. And then the other sort of like general sort of limiting factor or area where they can like limit things is services. What services will they reimburse underneath Medicare if you provide it via telehealth? And prior to COVID-19, it was probably about 100 specific CPT or HCPCS codes. So out of like a possible 10,000 that Medicare actually reimburses for. So they weren't doing a whole lot because they only limited telehealth to about 100. During COVID-19, they did expand the list to add additional like 80 plus codes. So we're up to like about a little less than 200 different types of codes that they will reimburse for if you provide the service via telehealth. Next slide, please. What follows are a bunch of other sort of, I don't want to call them ticky-tack, but they're more specific types of barriers that were underneath the Medicare program that inhibit the use of telehealth that CMS recognized, we need to change this if we want this to be more robust and more available to people. So there were a couple of things here that, I'm highlighting. One of them is a facility fee. Now for, again, in your cases as a long-term care facility or as a SNF, so I have to qualify, skilled nursing facility is the only facility, I think, for your grouping of folks here who would qualify underneath Medicare to act as an originating site pre-COVID-19. Now it could be basically anybody during COVID-19. But for the facility fee, that's a fee that they give the originating site to help them offset costs. It's not a lot of money. It's like about $40, but it offsets some of the costs that the originating site faces when they're doing like a telehealth interaction. That is really just here during COVID-19. That would just only still apply to like skilled nursing facilities. So if you're a different type of long-term care facility that's not a skilled nursing facility, you're not on that originating list of eligible originating sites pre-COVID-19, you would not get the facility fee. But if you're a skilled nursing facility, you would. So the other things that they allowed as well is, there's questions of like, I need like a prior existing relationship before I can use telehealth? And they said no, they didn't. You don't need to have that before the provider uses telehealth and sees a patient. Co-pays and out-of-pockets, they still apply, but Office of the Inspector General said they'll give flexibility to providers in like their collection of it, which helps them avoid some issues around Stark laws and anti-kickback laws as well. So they say they'll give you some flexibility, and you're going to see a lot of some of that through what we're going through. It's that whole term. We'll give you flexibility on addressing that, which is our next one, which is HIPAA, which they have said that they'll exercise enforcement discretion and waive penalties. So again, for HIPAA issues of like, can I use certain types of software to like really ramp up my telehealth program quickly? And they're saying that we won't fine you at this point, and we'll give you some leeway here. But I and the other telehealth resource centers have been recommending to providers who are starting telehealth programs, saying like, they're giving you this flexibility, but there's like a lot of options out there to help you ensure that you are still HIPAA compliant. Go with those. It'll save you a lot of headaches down the road. And also, if you continue on with telehealth past COVID-19, when they like remove this temporary waiver, you don't have to like sort of like restart everything and look for like things to make you help you be HIPAA compliant, and you don't have to disrupt your patients either. So just start off well from the beginning. You have a lot of options, just like go that route, and you have like a lot less sort of cleanup or changes that you have to make later on. Licensure, a lot of folks probably heard that the feds were relaxing licensure, and what did that mean? Because licensure is actually controlled by the states. So what that meant was that they were relaxing some of the Medicare requirements around licensure, such as you need to be licensed in the state that the patient is located in. So they're saying that you don't have to be that, but you have to meet certain conditions, and the conditions are, like you are licensed in your home state, and also there's no outstanding sort of cases against you in the state that the patient's located in. So it's fairly reasonable what they're asking for. Next slide, please. So again, these are some of the more detailed and fine policy issues that are in there that they're waiving, such as like for dialysis patients, like an in-person visit that they needed to get. They're saying they can allow them over telehealth. A quirky one here, and this did impede the expansion of telehealth because of providers' willingness to provide telehealth, is that third one. Providers needed to put their home addresses down. So prior to COVID-19, if a provider was providing the telehealth interaction from home, they actually had to put their home address down, because CMS said you need to write down where you were, the address of the location you were during the telehealth interaction. Providers are saying, I'm at home, but you're asking me to put my home address on the claims form. That's actually public information, that claims form. Anybody can find out my home address. So that really discouraged some providers from actually utilizing telehealth for Medicare patients. So CMS, recognizing that could be a discouraging factor, waived it. So that's what some of these items are like discouraging factors that they're trying to make easier so more providers would use telehealth. And here, that may be of an interest of you, some of those additional codes that I mentioned that they were putting in, they did include initial nursing facility visits. Those codes are eligible to be, or services are eligible to be done by telehealth and get reimbursement. And then there was an expansion of audio only services. Those were the CPT codes that you could do over phone. Recognition that not everybody has access to the telehealth technologies. All they may have access to is a phone. Next slide, please. again, something that applies to you guys are the frequency of visits. So prior to COVID-19, there was, and I'm not quite sure why, but there was a limitation on how often a SNF could have a telehealth interaction for a patient, and it was once every 30 days. I don't know how they came up with that number, but that was something that was on their on their policies, and they're waiving that, as they were waiving for like some of the other frequency limits as well. And then I mentioned earlier some of the Stark laws of relaxing some of those in order to, encourage greater use of telehealth, and then supervision and supervision requirements too, of like, can you do supervision over telehealth, like a physician over like maybe a resident. So like relaxing some of those rules as well. Right down below there are links to where some of these policies can be found. So you like have the actual language or guidance that CMS has put out. Next slide, please. I'm going to go over these next couple of slides fairly quickly because it gets it really in depth in what FQHCs and RHCs are allowed to do. And I don't think you guys need to hear that. I did want to keep this in here because I think likely they may be that telehealth provider providing services into long-term care facility. And I just wanted to point out that at least underneath Medicare now, they have that flexibility to do that during COVID, that they can provide those services. And that's been a big thing for FQHCs and RHCs. So I just wanted to make you aware that that provider group is out there available to you. Next slide, please. Only problem is they got some limitations on them. And one of them is that the rate that they're going to be paid is actually less than what they typically get. So next slide, please. So usually for those who aren't familiar, FQHCs and RHCs get a special rate that's calculated. It's a pretty complex formula. I'm not even quite sure how it works, but they get a special rate for each visit that they do. And it's usually a little higher than what you would see in Medicare fee-for-service because of the way that they're set up. They're supposed to like serve people, whoever comes through their door, regardless if they can pay or not. So they're giving like a higher rate to sort of offset those costs. However, when they use telehealth, Congress essentially said it because it was in the bill, has said that, well, we'll let you guys use telehealth and act as a distance site provider, but we're only going to give you $92 for each visit. So that's likely going to be lower for a lot of FQHCs and RHCs. Could be higher for some, but it could be lower. So while it opens up the availability for FQHCs and RHCs to act as a telehealth distance site provider, that may still act as a little bit of a discouragement of like, oh, we're not getting what we typically get if we provide the service. So I just wanted to put that out there as one of the things that, yes, this grouping of providers may be available to long-term care facilities and SNFs during COVID-19, but it might depend on whether they want to do a telehealth program. They may find it may not be cost effective or worth them doing it. Next slide, please. And then that's just like, more sort of information on that. One thing I did want to point out, because this is not just for FQHCs and RHCs, so there's informed consent. So when you have a telehealth interaction, Medicare actually does not require you to get informed consent from the patient prior to doing the telehealth interaction. But for those communication-based services or technology-based services that I'll go over in a moment, there are some consent requirements. And also states, a lot of states also have consent requirements as well regarding telehealth. So keep that in mind as well, that even though it's not required in Medicare, there may be a state law or a policy that may require you to get that before the telehealth interaction takes place. It may not be on the skilled nursing facility's burden for them to do it. Usually a lot of times they have it on the telehealth provider to secure that, but sometimes they do have it on like the originating site for them to also get that consent, or at least have a record that the consent was obtained. Or what usually happens, like with a telehealth program, is that the specialty provider, the telehealth provider, works it out with the originating site to get that consent there before, like, they do the telehealth interaction. Next slide, please. This is really complicated FQHC stuff. We don't need to go over that, so we'll go to the next slide. Virtual communication-based services. So again, this is related to FQHCs, but let's go to the next slide because this is probably a little bit more better slide than that one. That's specific to FQHC. So these are those technology-enabled communication-based services. So these are those other buckets of services that Medicare will cover that use telehealth technologies, but they do not call them telehealth. So they are not held to like the restrictions in federal law regarding telehealth services in Medicare. So these are a grouping of other services that, again, use telehealth technology to provide some types of services that have their own sort of restrictions and requirements, such as getting informed consent, but don't have typically the telehealth limitations of like, oh, it must be in a rural area or non-metropolitan statistical area or needs to be in a health facility, etc. So the first grouping are your virtual check-in codes, and it's exactly what it sounds like. It's a virtual check-in that's really quick. It's supposed to be 5 or 10 minutes. It's not supposed to be as a result of a visit that took place 7 days before, or results in a visit like within a couple of days afterwards. It could be over phone or live video and store and forward. So it's that quick check-in. Does not pay a lot. It pays about $10 to $15 depending on where you are. And a word of caution here. So you can use phone to provide this. And what I've noticed with a couple of states where they said, hey, we're allowing you to provide services over phone, they're talking about these virtual check-in codes, which I know that's tripped up some providers, and where they've said, I did telehealth and I only got paid $10. And then when I dig deeper, it's like, well, you were actually doing a virtual check-in, and that's why you got paid $10. You were billing these codes. So that's available there, and it is very useful for those quick check-ins and everything, but I don't want people to get them confused with like, hey, I did telehealth and I got paid $10 as a provider. It's like, well, you did the virtual check-in. So even technically, if you were under Medicare, they don't consider that telehealth. And that's why you got the $10. So keep that in mind there. I know this is like really confusing, and it's because people use different terminologies and they have different policies, but I've been trying to sort this out as best as I can for you. Interprofessional internet telephone consultations, this is your e-consult codes. CMS does reimburse for that, and interestingly, they reimburse for both providers. They reimburse for the provider who requested the consultation and the provider providing the consultation. Again, usually primary care and your specialist. Some states that reimburse for these, they actually only reimburse for the specialist time. So it's kind of interesting that Medicare reimburses at both ends. You notice when I was going through the Medicare stuff, I did not talk about remote patient monitoring. I was talking about live video most of the time with some mentions of store and forward. It's because CMS, and where they're talking about remote patient monitoring, they have them underneath these types of services, and they call them different things like chronic care management, complex chronic care management. This is where you get your remote patient monitoring services underneath Medicare, and you get reimbursed for that. And they have very specific types of definitions and services that take place underneath here. And then you have something called online digital evaluation or online medical evaluation. So where you go through some sort of online portal in order to receive services here. And again, very specific in like, what they consider. Each of these codes, they have like their own definition. So if the definition for what you're using fits into the code, you can build that. Next slide, please. One other thing that I think will be important for your folks that is federal policy is DEA policy. So controlled substances and how that's regulated, that comes underneath federal jurisdiction. So it's federal law. And where telehealth is concerned, federal law says there's like a narrow band of exceptions where you can use telehealth where the telehealth provider has never seen the patient in person and conducted an in-person physical exam. And these exceptions for telehealth are very narrow. There's like about 6 or 7 of them, and they are something like the patient's in a DEA registered facility during the time the telehealth interaction takes place, or was with a DEA licensed provider when the telehealth interaction takes place. One of the exceptions is when a public health emergency is declared. And a public health emergency has been declared. So the DEA has said that exception is kicked in, so you're now allowed to use telehealth to prescribe if it's for a legitimate purpose, if what you're using is live video, again, back to live video, can't be the other modalities, and that you're acting in accordance with state and federal law. Now, the DEA, again, came out with something else, and this was a bit of a surprise for me, is that they said that if you are treating somebody who's suffering an opioid use disorder, you may prescribe buprenorphine or Suboxone, I think is the other name, if certain conditions are met over the phone. So this is like the one area where they have the exception of you can use something other than live video. You can use the phone to prescribe if certain conditions are met, and there's the letter for that, the guidance letter, and it's only for opiate use disorder, and it's only for the prescription of buprenorphine. So that is another exception that they have made for, a modality of in like providing a service. Next slide, please. Now, what's going on the state level? And I know I've been talking for a long time, but we're almost done. So what's been going on the state level is that prior to COVID-19, you actually had a lot of Medicaid programs reimbursing for at least something in live video. You had all of them doing that. Store for and remote patient monitoring, a little bit less popular and a lot of caveats involved and for very specific types of things. So store and forward, it was like dermatology or ophthalmology, remote patient monitoring, usually for some sort of chronic condition. And that's important to notice because if they were doing that in remote patient monitoring, that's usually where they said the service could take place via telehealth in the home, was for this remote patient monitoring service for this specific condition. So you actually had a lot of states not saying that you can use telehealth in the home unless it was for this very specific type of thing. Next slide, please. You also have states who have private payer laws, and what these are laws that direct private payers and how they're supposed to treat telehealth. And you had a range of them from states that said, health plans, you can cover telehealth if you so wish, all the way to health plans, you will cover telehealth delivered service the same way you did in person. And by the way, you're going to pay the same amount for that. And then everybody else falling in between. So you have to read very carefully what the state law says, what they're requiring, because a lot of them are written that in a way that gives like a little bit of flexibility to the health plans and what they can cover. So they may have terms such as like, oh, subject to the contract between the provider and the health plan, or, subject to the terms and conditions of the policy. So keep in mind that, there's actually not quite a lot of states that kind of plugged up those flexibilities and said, like, you're doing it the same way if it was in person, and you're covering it for the same way, and you're paying the same way. So that was out there as well prior to COVID-19. Next slide, please. What we're seeing with COVID-19 as far as like emergency waivers on the state level, these are the most common things that we've seen in like executive orders or what Medicaid programs are doing. And that's the first one, big ones, allowing the home to be an eligible originating site. So I mentioned earlier that if they were allowing the home, it was usually for something very specific as opposed to saying like, oh, whatever telehealth, whatever you can provide via telehealth, we're going to cover if the patient's at home. It was usually for something specific. Most of the states are just saying like, it can take place in the home, whatever services. Allowing a telephone to be used to provide the service. Now, prior to COVID-19, and I had mentioned earlier that a lot of states had on their books in law or maybe in their Medicaid policies a specific definition for telehealth or telemedicine, depending on what term they're using. Practically all of them excluded phone from that definition. So when you look at these executive orders, you'll see them saying like, we're going to expand telehealth services and telephonic services or telephone services. And they had to do that because if they just said telehealth, phone would not be included because their definition of telehealth in that state did not include phone. So again, this is recognition that not everybody's going to have access to the telehealth equipment, a laptop or a smartphone. So they have to allow phone to be used as well. But I also mentioned that be aware, some of these states, when they're saying that, they may just be saying like, we're only reimbursing for the G2012, G20110, those virtual check-in codes, those quick check-in codes. Then providers find out it's like, I only got $10 for that consultation I did. It's like, you built the G code. That's why, because that's all they were covering. Health plans are doing that as well too. The one sort of like discussion I saw or heard about was he did say it was a commercial health plan. It was because he was told to build the G code, and that's why he was getting $10. And then the other sort of common policy change we're seeing on the state level is requiring health plans to cover telehealth or encouraging them to cover telehealth, some direction to a health plan. And it's going to vary depending on the state on like how far again they go with that. Some of them have been saying like, we encourage you to like cover more telehealth services. To other states, maybe because of the laws on their books, are saying like, you're going to cover this and you're going to do it this way. Next slide, please. So these are sort of less common changes, but they are policy changes we're seeing on the state level, and that's expanding modalities beyond phone. Some of that may be simply because their definition encompasses like store and forward, for example, and they're saying like, we're going to expand telehealth services. So they haven't like come out and said like, we're expanding store and forward services. They've just kind of like included that in their general definition. But that's not been as popular like it's announcing like we're covering more services by phone. Expanding the eligible list of providers to include other types of professionals. So allied health professionals a lot of times are left off as eligible telehealth providers. So your PTs, your OTs, again, people I think who are probably providing services to skilled nursing facilities that would be important to allow them to at least have this tool to provide services, they're being left off in a lot of places. Although there's been a lot of talk then that, let's see if we can do this. They're left out of Medicare. So keep that in mind. And then waiving consent requirements. I had mentioned earlier that actually a lot of states have consent requirements in regards to telehealth. So it's not as widespread as some of the other sort of waivers we're seeing, but there is some relaxing of like consent requirements that we are seeing out there. Next slide, please. So I heard that Michigan, Minnesota, and Wisconsin were kind of the states targeted, even though I do know there's other folks from different states here. So I just wanted to go over some of what that you guys had pre-COVID-19, some of the policies. And for the most part, it looks like, you know, you guys had citizen eligible region site, which is like, you know, great. But then you sort of like start deviating from like what's allowed, and you can see the differences going across states. And that, you know, Michigan only in their Medicaid program only allowed for live video, whereas Minnesota allowed for all three modalities, and then certain things that they were covering. Next slide, please. This is what we saw at least in their sort of emergency waivers to come out. You know, again, they're following the trend of like what most states are, and what we saw is like they're allowing the phone to be used as a way of providing services from a distance. So they're following the trends of what we're seeing like nationwide with the other states in regards to telehealth or expanding, you know, virtual care. Next slide, please. And that's it. And you're probably all relieved because I talked for a long time, but these are just links to some of like the information we have. As I mentioned earlier, our 50 state does not include the COVID stuff, but we are tracking it. So we have a special page devoted to that, where we're tracking what's going on the federal level and also on the state level. Also, you're more than welcome to subscribe to CCHP's newsletter. Whenever we see something out, we put out an alert on that. Typically, I say, like, we only send things out once a week. Can't guarantee that now during COVID. So we send stuff out as soon as it becomes available. So more than welcome to join our newsletter to get that information if you want. Next slide, please. And I think the next slide is just my ending one of like an email address where, yeah, if you don't get your question answered today or you think about it later, feel free to like email us. We're more than happy to take your questions. Like, not even during the webinar. So that's it.
All right. Well, thank you, Mei, for an excellent presentation. We've all really enjoyed it. Just a reminder that if you do have any comments or questions, you can put those into the chat box, or if you've joined us by phone and you want to ask a question, if you press *6 on your keypad, that will unmute you. And then once you've asked your question, you can press *6 again to mute yourself. So Julie, are there any questions or comments that we have that have come into chat?
Yes, we do have a question. Can you point me to a resource or resources that will tell me what codes to use and what the reimbursement rates are?
If you look at the PowerPoint that I had, underneath the services slide when I was talking about CMS, there's like a little link that says here. That actually will take you to the CMS listing of codes that they have. That's Medicare. So your Medicaid program might be different. They may actually have different codes that they are reimbursing for. But for Medicare, there's a link in my on that particular slide, and I think everybody gets access to the slides. There's a link on that slide underneath the services, the chart that I had for like the CMS changes for services. You're going to see like a here thing of like where you can download the listing of service CPT codes that they are actually covering.
Thank you. We do have an additional question. Are you seeing movement towards standardization of terminology on a national level or an increase in the frequency of conversations related to standardization? And what do you
Yeah, go ahead.
oh,
Sorry.
I'm sorry. What do you perceive the greatest barriers to be if that's not occurring?
So there's definitely increased conversation in the telehealth field. I'll be honest with you. I think right now the policymakers are more sort of in crisis mode and addressing. And I have to give credit to CMS and state governments and so forth. They are moving so fast. This is like fast as I've ever seen them move, at least where telehealth is concerned. So they have to, there needs to be like a little bit of patience given to them. But right now, I think a lot of the policymakers are like, we need to address this immediate crisis. What do we need to do to address this immediate crisis? So I don't think they're thinking of standardization or really thinking like, what's the next step once we get past COVID in a lot of ways, where telehealth is concerned at least. But that has been a serious topic among the field, and I think it's become very apparent. So I always worry when I give this talk to like these talks to like a new audience, because it is so it was so complicated pre-COVID-19. It's even more complicated now with all the quick changes. And I think a lot of providers are realizing this, because now you've got a lot of new providers coming into telehealth and they're going, what the hey? I'm like, I've got Medicare, Medicaid patients and private payers, and they're all telling me how to bill differently. Like, you know, Medicare is asking me to use the 95 modifier, but my Medicaid program is asking me to use GT. And then this health plan is asking me to use something else. Can we just get sort of like standardization across the way? It's always been sort of like a topic that's been discussed like pre-COVID-19, but I think like everybody were thinking we had time to talk about it and think about it thoroughly, but it's become very apparent now that this is sort of a issue. Now, federally, I've not heard about standardization. I can't say about on the state level, although I'm pretty embedded into California. It's because we're located here. We started off as a California program, so I have a little bit more connections and I hear a little bit more. I was starting to get, at least in California, a couple of inquiries when I brought up the issue of like, you know, this has been a problem. It's very confusing for providers. That maybe there might be like in some of the on the state levels, if they hear of it, that they may try to do a little bit more standardization. But as far as something nationally and going across multiple states, we're probably a little bit far from that now, but you might start seeing states trying to like do a little bit more ordering on that. And that's not surprising. Even before COVID-19, a lot of states were a lot more advanced than what was going on nationally, like on the federal level with CMS, which again, not because of CMS, but just things were embedded in federal law. It's just harder for them to move. So that's kind of my answer there. You may start seeing it because it's really kind of exposed it as being like an issue during COVID-19. A lot of issues have been exposed during COVID-19 that we'll probably see people at least getting momentum to address it once we're past this initial crisis.
Thank you. We do have another question. Can you explain more about the SNF originating site fee per visit?
Yeah, so this is Medicare. Medicaid differs depending on what state you're in. So Medicare has said for originating sites, pre-COVID-19, they were allowed to have something called an originating site fee. It's that really just to offset their costs of doing a telehealth interaction. Again, not a lot of money. It's like about $40 or something like that. With COVID-19, you've allowed like basically a whole bunch of sites to open up and be available to act as an originating site. And what CMS has said, like, well, all those sites that we open it up to, we're not going to pay you an originating site fee. But those folks who were already on the list pre-COVID-19, like SNFs, you're eligible to receive an originating site fee. I think where there may be an issue, though, with that is if you were a SNF located in an urban area, you suddenly became like an eligible site underneath COVID-19 because they removed the geographical limitation. I don't think you're eligible to receive that facility fee because you came in underneath the umbrella of the COVID-19 waivers as opposed to being like pre-COVID-19 eligible originating site. They're saying pre-COVID-19 eligible originating sites, you guys get the facility fees. All those folks who came in like underneath the COVID-19 umbrella, you may not be, but I'll need to double check on that to make sure that that's right and what I'm remembering. Basically what they were trying to also say, I think really in their minds was, if this is taking place at home, we're not going to give a homeowner $40 because you're an originating site. So I think that was sort of like the main thing they were avoiding. It's like a lot of people are going to be at home. We're not going to allow you to get the originating site fee if you're at home.
I just
Oh, is it paid? I saw that as a paid per visit. Yes, it's paid per telehealth interaction.
Thank you, May. I just want to remind people that there will be a survey, a short survey, of evaluation survey posted in the chat box, and we would really appreciate any of comments or feedback you have for us. It helps us to plan other additional events like this one. And I know we're nearing the top of the hour. Julie, is there any comment or another just quick question that we might be able to entertain?
We do not
Tony,
have any further questions.
Okay, and Tony, that facility fee question, I'll double check on that one and I'll send the answer to you so you can send it out to folks.
Okay, perfect. Thank you so much. Any additional comments or questions, Julie?
No additional comments or questions. Thank you.
Okay, well, on behalf of Superior Health, I really would like to take the opportunity to thank you. This was a wonderful presentation, gave people a lot of food for thought, and just interesting environment that we find ourselves in given the COVID-19 crisis. So thank you once again. We really appreciate your time.
Thank you for having me. And again, I encourage you to reach out to your telehealth resource center if you have other questions, or reach out to CCHP.
Perfect. Thank you so much, May.
All right.
Take
Have a
care.
great day, everyone. Stay safe.
Thank you, May.
Bye-bye.